Yes, ma'am. All good, ma'am.
All good. So we'll start then. So good
Sure.
afternoon, everyone. Today we have Dr. Hari Shankar as our speaker. Dr. Hari is a MD biochemistry. He did his MD in 2016 when he was awarded a silver medal. After that, he has been with the DDRC now for the past 5 years. He heads the Department of Biochemistry and Immunology at DDRC SRL, based in Kerala State. So, Dr. Hari, would you start your presentation, please?
Okay. Thank you, ma'am. So as time is with you, I'm directly going to this presentation. So right away. So more or like today, I would like to talk about a story rather than just being in the topic. Okay. So this thing will be going as a kind of story. Along with that, some essence of topics too. Okay. So is the slide changing?
We'll see
Not
your
yet.
first slide. First slide is there.
I'll share it once again.
Sure.
Okay. Now it's changing now.
Yes.
Okay. So in terms of biochemistry, even though the lab is having a lot of disciplinaries apart from biochemistry, the most important hematology part, I mean the pathology, microbiology, everything is there. So in terms of biochemistry, when the point of concern of special test starts, at one point of time, the special test was TSH. Okay, now the special test grade has gone much more in the higher sense, and now it starts ranging from double marker, to be frank. Okay, so I know I can tell that the name of this test by other names other than double mark, something like combined screening, okay, first trimester screening and everything. But I'm deliberately telling double marker because I feel like that in terms of biochemistry hormones, I mean the hormones department of biochemistry, these two tests, TSH and double marker, they are going to stand forever till the modern society medicine and the modern medicine prevails in the society. Because we all know about the importance of double marker, without doubt. I'm not going to lecture more about the importance of double marker, but it has its own flaws and its own advantages. And much more higher versions of first trimester screening has come just by adding more and more parameters to double marker. Okay, so even if you keep on adding the more parameters to double marker, the price concern and the reachability to the common man, all these things can be an issue. But the first trimester screening is one of the most important things that has to be done as a part of gynecological screening. So as a part of an economic concern, and all people should do it. Okay, so double marker, I think the free beta papa double marker, they are going to stand forever. So who should be trusted when it comes to double marker? So people may tell, some people will concern only about price. They will tell, or they will concern like that, I will trust only a person who will offers a low price. Some people may argue on the terms of quality. Some people, they will argue in terms of technology. Okay, and a group can also argue in terms of experienced team. But I tell, the word trust applies to a cocktail of all these. It should be a price should be a concern, of course. Okay, but it should comes with a documented quality, not simple any namesake quality. I always used to tell, or I always should believe, the quality should be documented. Then only it should be considered. That's the thing. So there should be the thing related to true documented quality, and there should be an experienced team. But an experienced team is of no value if it is not motivated. An experienced team is of no value if it doesn't have any knowledge or commitment. Okay, so the one who has already proven his metal with a true documented quality and highly motivated, experienced team powered with knowledge, commitment, and superior technology can be trusted. As a doctor, I'm telling you, not as a lab person, I'm telling. I'm just telling as a doctor, this kind of people can be trusted. And I hope most of you might know about the logo dialogue of SRL Diagnostics a few years back. I think it was like trusted by millions. So we are going to highlight on that word trust. Okay. So keep the word trust in the mind and we'll start the story. In the story, we are going to, as he told, we are going to tell about double marker. Okay. So we know double marker, it is done in the first trimester part. The blood and the scan report taken at the time of 11 weeks, between 11 weeks, 0 days and 13 weeks, 6 days. Okay. So before approving a double marker result, okay, we all know if we enter certain inputs to the software like age, date of birth, blood parameter values, scan input values, if we enter these things, the software will show a result. Okay, that anybody can do. There is no need of a doctor or no need of a team. We just need some people to enter the value. We just need a reagent and a machine. Okay, by these things, we can surely make a double marker report. Okay, but before approving that, certain things has to be considered. Okay, so I can tell you a few certain things. I'm just only noted only 5 important things over here, but it is more than that, and you will be knowing that as the presentation progresses. So one of the main thing is maternal age. Maternal age greater than 35 years. We used to call it as advanced maternal age. Any kind of abnormality in ultrasound result. Okay, that can be CRL problem, that can be NT problem, that can be nasal bone presence, absence, admin, ossified, unossified, excuse me, even hypoplastic. Okay, then comes to the previous history of the respective patient. Then comes the abnormality in the blood values, blood analyte values. That means and the abnormality in free beta and papa values, free beta HCG and papa values. If free beta HCG is high, very much high, that can affect the result. The free beta HCG is low, that can also affect the result. If the papa is high, that can affect the result. If the papa is low, that can also affect the result. Okay, but remember, the result are always based on a combination. Okay, the interpretation should always be based on a combination. Okay, when it comes to Down syndrome risk assessment, if we are considering only blood parameters, the combination is in such a way like that free beta HCG will be high and papa will be low. And my kind concern is we never should take the raw blood value into concern. MOMs are always better. Okay, let's progress with the story. The story starts like this. Here comes a 29-year-old female comes to a hospital. There, he comes for her routine pregnancy check. Okay, as the time for her pregnancy check was the first trimester time. Okay, the clinician, the gynecologist, prescribed her double marker test, combined screening. Okay, as she was due for it. Okay, so as we are in as we DDRC SRL as are associated with that respective hospital in terms of business and service, the hospital has provided us the blood sample. Then apart from that, of course, they have provided the prenatal screening form and the and a copy of ultrasound scan. Okay, so but apart from this, we also have certain protocols. We also have certain extra forms. Those are, there is a pre-analytical error assessment form we used to take for every double marker result. Okay, I will come to that later. Okay, so all these documents were submitted to us along with the blood sample. So we checked the documents, we just made sure in such a way like that the sample is eligible for run. We ran the sample on eClear technology on Roche platform. Okay, and we estimated the risk in SSW software version 6.3. And so the result were as follows. Okay, so the thing comes as like this. The free beta HCG value was 25.51 units. Okay, I'm not going to tell every time unit per liter, milli-unit unit per liter. I'll just tell unit for now. Okay, the free beta HCG of that patient's value was 25.51 units, and the respective MOM was 0.76. That was pretty normal. Then, coming to the PAPA data, the raw value of PAPA, the direct blood value of PAPA result of that patient was 50.45 units. 50.45. When it comes to its MOM, the MOM was 0.02. Very, very low. Okay. So as MOM was very, very low, what happens is, see the combined screening result. When the result, of course, we are assessing the result based on T21, T18, and T13 aspects. Okay, the T21 risk was 1:1053, T18, T13 risk was 1:1. And we all know this 1:1 risk used to come. The people who used to do rebel marker or the screening regularly, we know this 1:1 risk usually used to come for some kind of patients who used to have some sonological abnormalities. Okay, so it was 1:1. So naturally, we are a team who never releases a double marker report just based on what software gives. Okay, so what we do is we just analyze the scenario. So we just see who was the culprit. We just want to see who was the culprit who is giving this data. Okay, so we just check the scan once again. Okay, we already checked it. We just scan once again. As a scan, the all report was normal. The free in the fetal heart rate, the respective CRL was normal, NT was normal, nasal bone was perfectly normal. The fetal, even the fetal heart rate was normal. Everything was normal. Then we taken the patient history into consideration. There was no history of documented previous anomaly, aneuploidies. Okay, but she got a history of 2 abortions previously. But anyways, that it was the history of aneuploidy was not documented. Okay, so unless otherwise it is documented, we cannot take it for sure. Then of course, as the IQC was good, I can tell the instrument is good. And of course, when we ask about any problem with the kids, of course, IQC can vouch for that. Apart from that, we are using an FMF approved kit that can be the value derived from which kit can be used in risk algorithm. Okay. Then regarding the quality, IQC is good, as well as our EQAS was also documented and it was perfect. And we once again check for the wrong entries. Okay. Rerun of the sample has been done. Okay, I forgot to mention that the rerun of the sample has been done. Okay, apart from that, any wrong entries, because we are entering directly to the software now. Okay, we check the wrong entries. There is no point of wrong entry over there. For then about the free beta HCG. Okay, we once again check that. Okay, not a problem. But who is the fellow who is responsible for this this kind of risk value? When we look at that, the PAPA MOM was low. So this is the only parameter in the whole scenario which is abnormal. So what that tells us? Okay, the problem can be a falsely low PAPA. So we come to a kind of conclusion like that. The fellow who is behind this problem is a falsely low PAPA. Okay, and remember, we also took care of other issues or other concerns into action. Those were like we have run the sample as per FMF. A double marker sample should be run within 72 hours of collection. Actually, so there is a guideline. I think this is a number 2 guideline in FMF algorithm. Given it is already in the internet. Okay, so anyway, we concluded that the problem is a falsely low PAPA. Okay, so next step, what we did is we communicated. We know one of the main trait of a professional lab is lab clinician communication. So as a part of that, we communicate with the clinician. We explain the scenario in such a word that she can understand. Okay, we doesn't put all kind of lab things into her head. Okay, and we also directly communicated with the respective fetal medicine specialist who is in duty of that hospital. Okay. As per their consent, what we have did is we have taken a new blood sample, as well as we ourselves have taken the history again, and they have that hospital has done the scan again. Okay. What happened is same pattern, same result. Okay, same pattern, same result. So different types of questions got aroused from different directions. Okay, so of course we know like everywhere we are also facing a lot of marketing challenges. Okay, so a lot of questions. Some of the questions has arisen from some point of area like that. What you people have done to make sure the reliability of Papa result? That was one question. Okay, and we were using Roche platform, and suddenly a question also arises in that way. Your technology, is it as good as PerkinElmer? Okay, that was another question. And one more interesting question came like that. Are you transporting and storing these samples perfectly? Is your transport and storage system perfect? This was another question. Okay, as a lab professional, okay, we surely has to explain these things, and we surely has to show some documents like that we are doing good. Okay, so as I told you, the questions are from 8 directions. Okay, so when a problem comes, then at that point of time, we can know who all are waiting for our to get to us. Okay, with a lot of questions, and also it's an opportunity to make ourselves better. Okay, so in that terms, actually, we were waiting for this thing. Actually, so the thing is that we came to know about the people are who can question us, and we also came to know like that what kind of question can be asked to us, and we got a crowd, okay, kind of crowd, a group, okay, so that we can express our might to them. Okay, so that means we got a lot of questions, and we make all these people into one room in such a way like that we can present our might to them, because they feel like that their questions, at least some of their questions won't be answered. Okay, so the thing is that we already know that such a case of false risk due to Papa value reliability had happened. And in this point of time, at this point of time, when this case was diagnosed 1.5 years before, okay, only one such case was reported in the world, and that is in only at UK. The article is available in the internet, and I'm really, by God's grace, I'm really proud to say that this is going to be the first case to be reported in India, probably in Asia itself. Okay, so just answering their question. So what we have done to make sure the reliability of the result, and we all know Roche parameters. Roche parameters are susceptible to biotin intake problems. When it is a sandwich assay, because of biotin intake, I mean only high dose intake, okay, biotin intake, falsely low value can get resulted. And remember, free beta HCG is also sandwich assay, Papa is also sandwich assay. Okay, so only Papa got affected. If the patient is, first of all, the most important thing is patient is not taking biotin. That is the most important thing. Okay, and even if just consider if even if the patient is taking biotin, okay, why only Papa got affected, not free beta HCG? Okay, so considering these two facts into action, we have ruled out biotin intake. And they asked about another question: what you had made sure to make, what step you have to you have taken to ensure the safe transport and storage of the sample. For that, we have a separate form regarding that, and that form is termed as pre-analytical error assessment form. Okay, in this, we are ensuring the reliability of, we are ensuring the reliability as well as the stability of the sample at the correct temperatures at 4 levels. 1 at collection center level, 2 at collection representative, the courier boy level, 3 at the analyzing center receiving staff level, and at last the 4th thing at the reporting doctor level. That means when a sample is taken at a collection center, they have to fill a few things in the pre-analytical assessment form. Okay, and I will show the form at the end of the presentation. Okay, And after that, the collection boy will come over there and get the sample. He have to fill 2 or 3 things on in the form. Okay, and that form along with the sample in that respective temperature, it will reach the analyzing unit staff, and they are trained in such a way like that they should follow a protocol and make sure the sample is eligible to do the double marker test. In that, they have to look at the, of course, we know this our basic stuff. They have to look at the sample appearance, any leakage of sample, whether it got under the correct conditions of temperature and everything. Okay, as I told you, I will show the form at the end of the presentation. Okay, and taking into these things all into consideration, then only the doctor will approve in that respective form, like that this sample is eligible to run, can run it. So the pre-analytical error assessment form is not just a form, it is a documented form. Okay, and analytical error check also we have done. So the problem is falsely low papa. That means low value of papa. Okay, one of the basic coming to the basic biochemistry, the papa is a positive enzyme. Okay, positively charged enzyme. That means it is a zinc containing enzyme. In the presence of any kind of negative charge like anticoagulants, papa can complex with anticoagulants, and that can lead to falsely low papa in the analysis. Okay, so it is well documented in the teeth also. Okay, so in this case, there is no chance of anticoagulant contamination, because we had made sure the most common anticoagulant used in the laboratory setup is K2 or K3 EDTA. Okay, so if we consider, if we just we have, and what we had done is we have just checked the potassium in that sample. Okay, if any kind of anticoagulant contamination is there in the serum sample, the potassium will be high. Okay, in this case, the potassium is not high. Okay, and also we have also checked ALP and total calcium levels also. Okay, so if the total calcium and ALP values are false, very low than to be expected in the pregnant lady, okay, we can also suspect about anticoagulant contamination. So these all things are, we just made sure anticoagulant contamination is not there by ensuring there is no high potassium and low ALP and total calcium. So analytical error check is done. Okay, that means there is no kind of anticoagulant contamination. After that, we have done an in-house interference study. This is the key. Okay, so my colleagues kindly make sure, kindly be attentive to this thing, because it can be very much useful for you. Okay, we have done an interference study. The thing is that we have taken the problem sample. The problem sample's value of papa is this simple max only. Okay, the problem sample's papa value is 50.45. 50.45. We also checked. We have also checked. We also taken another value. Excuse me. We have also taken another patient's papa value who got a regular normal value of 3000. Okay, what we did is we mixed equimolar concentrations of, equal volume of this normal patient value with the abnormal patient value. Okay, so what should be the expected result on the mixer value? That is normal sample value plus abnormal sample value divided by 2. That is nearly 1525. That means 1525.225. Okay, it must be nearly somewhat there. Okay, but that is expected value. But when we measure, the value which we got is 152. That is nearly only 10% of expected recovery. Only 10% of expected value. That means the problem sample is a real big problem sample. Some substance in the problem sample is not allowing in the papa assay antibodies to act with it. Okay, so I can call him as a kind of papa inhibitor. Okay, so of course we have done the control mixing study also along with that. That is okay. Okay, so the thing is that by this interference study, just by a simple mixing study, we made sure that this patient sample is having some kind of papa assay antibody inhibitor. Okay, so it's not the problem of the patient. to be frank, just some inhibitor thing. It's not the problem of assay. It's not the problem of our protocols. Okay. So the thing is that whether we have to make sure this PAPA inhibitor assay antibody, PAPA assay antibody inhibitor problem is there in other technologies also. One we made sure is we have run the same sample, because when we took the second sample, we have already planned in such a way like that we have to do other analytical comparisons. So based on that, we have taken enough volume from that patient. Okay, so other technologies also we do. We did in the all Prisca, I mean in the Siemens Immelite Prisca technology, as well as in Perkin-Elmer. What the result is? See the result. In Prisca, also the free beta HCG is normal. Only the PAPA is the problem. And as we know, the Prisca is more generous. It will give risk in T18. Apart from T18 and T13, it has given risk to T21 too. Okay. And when it comes to Perkin-Elmer, again, the value is somewhat similar to the result is similar to Roche. See, the PAPA MOM, the PAPA value is low and the MOM is also low, and the risk is attributed to T18 and T13. So based on that, and also based on reading nearly kind of 50 to 60 articles regarding these things, I'm telling you, whatever problem Roche is having, Roche kids are having, same problems Perkin-Elmer also has. But the only advantage is most of the studies has been of combined screening has been done in Perkin-Elmer. Okay, so coming to this. So the doctors told in such a way like that, actually I wrongly used the word, they confirm the patient is having risk, but they just assume the patient is having risk because as Perkin-Elmer is showing the risk. Okay, because in some areas, okay, it is very difficult to convince people about the genetic test and all other things. Okay, so they are being from a socioeconomic class, they cannot be reasoned beyond this beyond the horizon. So the doctors decided in such a way like that they will tell the patient like that there is no ray of hope. If you want to do, you can do an amniocentesis, something like that to confirm it. And also you have 2 history of abortions. Okay, you can abort it. This will be better like that. They decided initially. Okay, but the fetal medicine specialist was in a partial mind. Okay, to be frank, but the fetal medicine specialist had discussion with us, and in this case, she had discussed with me and asked me in such a way like that, what is your take as a laboratory professional regarding this? So I already told them, madam, I have already proved to you, this is a case of PAPA inhibitor. Okay, it's a chemical problem. Okay, and I also showed her the article. Okay, so I told her, you can go with a confirmatory study. It is not a problem, but don't tell. We have to somehow convince the patient to proceed with this pregnancy. Okay, we can go for confirmatory study. So by God's grace, they gained confidence and we worked as a team and we had done the amniocentesis, and that was the fish result came. It was normal. Then the karyotyping result also came. It was also perfectly normal. But still the aura of doubt is there because the PAPA is low in all kind of technologies which is known to people, known to modern medicine. Okay, in that terms, people, the madam is in a doubt in such a way like that. Maybe the all things were normal for the aneuploidy, but she will be having some kind of growth problems like small for gestational age. Maybe a spontaneous abortion can happen. PAPA is very low now. Lot of kind of adverse pregnancy outcomes can come. Okay, so the fetal medicine specialist started counseling the patient regarding the adverse pregnancy outcome. Okay, on the same time, they have been counseling and they have been continuous touch with also. So we being very positive by somehow. Okay, so a series of scan has been done for the patient at the regular intervals. Okay, in every growth scan, the growth is normal. And in between, the same patient has went to another setup of hospital, okay, and also consult other doctors, and those doctors actually, as they haven't seen a study like this, they told in such a like that you can either you have done the amniocentesis, okay, it is normal, but this is a heavy risk, and we cannot watch for this, like that they told. Okay, the thing is that I still believe the essence of double marker, the reliability and everything hasn't penetrated enough into our doctor society. Okay, it's the limitations as well as its reliability and everything. Okay, so anyway, coming back to the story, the series of scan has been done. The growth of the baby is normal in all scan reports, and there is no soft markers also. Okay, regarding any aneuploidy. So and the fetal medicine specialist was just waited for the birth of a child which is going to be a career boosting case. Okay, so the child was born. It was a normal pregnancy, not even a cesarean. Okay, and to be frank, it is a healthy baby boy. Okay, and by that also the thing is not end. Okay, at this point of time, pediatrician was not sure. Okay, and that point of time, a karyotyping was done for the baby, and the result of karyotyping was also normal. And by the time I'm speaking, by God's grace, the baby is still kicking good. Okay, I am in touch with them for every month actually. So this is a detailed study we have done. We have started from double marker. We have done the amniocentesis fish. We have done the amniocentesis karyotyping. We have done a series of scan study. We have done analytical comparisons. We have done interference study. We have done even the karyotype of the baby which is born. Okay, so there comes the insights. Okay, before coming to the insight, this was the first case which have got committed this much, because if I gone wrong somewhere, it would have affected my career itself, to be frank. But I followed up nearly like, even though the lady was carrying the pregnancy, the pain was there for me also till the baby comes out, to be frank. Okay, so after this case also, I have gone behind these kind of certain parameters and certain results. Okay, but I have never seen a case like this till 2 weeks before. Okay, I thought this was just a matter of luck, but not. Just 2 weeks before, a same type of case has again been diagnosed by me, and its karyotyping is also done. It is also normal. And so what I'm gonna inform you is, what I like to inform you is, in certain aspects of thing, double marker is just beyond giving entry to the software and giving a direct software result. There is a sort of commitment by us doctors and us, the team, while releasing the double marker. Anybody can give a double marker if they have a kit, a good machine, and the software. But the professional work behind that thing is something which other people cannot do. Okay, so coming back to the insight, is free beta HCG always reliable? I will tell no. Is PAPA always reliable? Again, I will tell no. Whether all double marker details are verified and approved directly by an MD doctor in all labs? No. And how a lab will support a doctor if some trouble related to double marker comes to support to hold up the goodwill of the doctor? These are the questions or insight actually a customer, can be a customer or a doctor or a hospital, ask. Okay, so while approving the results of double markers, certain things we should take into consideration. Okay, apart from the point of view of this particular case, there are certain conditions which can falsely elevate the free beta HCG level. Okay, number one is fever. If you take a patient double marker sample at the time of fever, okay, because I have seen this pattern in the case of during the COVID time. The people who are having high IL-6 and taken sample for double marker, free beta HCG value was high. And there are enough article evidence showing that the IL-6 concentration is directly related to the increase in free beta HCG levels. So fever, acute illness, that little bit of inflammation only now. And in some cases, HCG injection, as you know, HCG injection and free beta HCG relation, and preeclampsia and HCG also got a relation. Opioids, PTH. Here comes the most common fellow, T3. T3 can increase free beta HCG levels. Okay, and remember, some conditions can elevate PAPA also. Even though, actually the thing is, we are telling about the PAPA, this parameters PAPA. Actually, we should tell it is not PAPA. This is PAP-A, pregnancy-associated uh, plasma protein A. So actually, this is PAP-A. Okay. So in certain conditions, PAP-A value will be high because PAP-A is released, we think like that PAP-A is released by placenta of a pregnant lady. No, PAP-A can be released from other tissues also, especially those who are having a remodeling capacity, like bronchial muscles. People who are having asthma or allergic rhinitis, PAPA can be higher. People having myocardial infarction, it's not myocardial rhinitis, my bad, myocardial infarction, they can have high PAPA. But luckily, that myocardial infarction PAPA assay and pregnancy-related assay is little different, but we can come to that point at some point of discussion and some kind of other section. Okay. Then preeclampsia is also related. And also I have seen a pattern of increased PAPA in patients who are having low low body weight. Okay. If the body weight of the patient is somewhat related to 30 and 35, okay, do not trust on PAPA. This is my kind of scene, pattern which I have seen. Okay, right now I doesn't have any proof to tell the relation of body weight with the PAPA. Okay, but one thing is already documented: as the weight increases, PAPA decreases. Okay, but as the weight decreases, we doesn't really have a documented evidence stating like that the PAPA increases. But kindly mark my words: the body weight is somewhat near to 30 to 35. Do not rest on PAPA values. That PAPA can be slightly falsely elevated. So these things can affect the PAPA value. So how we can take this information into a hand or into a practice to channelize the results. Okay. So in certain cases, we can channelize. A double marker is also not always reliable, Okay. Because of these kind of factors. In these kind of cases, we can channelize double marker results to follow-up studies. It can be a quadruple, it can be a 4D anomaly scan, okay, it can be an NIPT in times, okay. So, because as I told you, the non-reliability of PAPA in the cases of fever, acute illness, the thyroid, asthma, allergic rhinitis, etc., etc. These things can affect double marker result. Double marker result may be falsely normal, but a real risk can be there, which can be masked. I will just tell an example. Okay, if a patient is having asthma and she came and take the blood sample, her PAPA value is falsely elevated. Okay, and because of that, her free beta HCG MOM is in the brim, okay, of high side, and PAPA is normal, and the ND values in the brim of nearly somewhat 2.21, 2.2 to 2.4 MOM, okay, to MM, okay. But the software will show a normal risk only because the contribution of PAPA from an asthma patient will falsely mask the true deficit of the PAPA of the respective pregnant patient. So in these cases, you can take these pre-analytical considerations into consideration, as well as the use of certain special MOM cutoffs can also be taken into consideration. And those special MOM cutoffs is not my point of presentation today. That's why I'm not sharing that now. Hopefully, we'll be sharing it in another presentation. Okay, those things can also be considered to channelize double marker result to quadruple. I won't advocate triple mostly, but at least to quadruple or NIPT even. Okay, these can be considered. And if you want to consider take or channelize certain report to NIPT, because at the end of the day, what really matters is, of course, the result. But a contributing attribute of that result is goodwill. Our goodwill, the goodwill of the referring physician also. So it is our responsibility to keep up both of our goodwill. Okay. So if we don't trust on the normality of the double marker software results, okay, we have something extra to do always. Okay. So if you have some kind of doubt regarding the results, there is an online FMF algorithm which is already available. In that, you can consider fetal heart rate also into consideration. Okay. Well, you can, in that, the population will be South Asian. Okay, that can also be used. You can add these things in the observation slot. Okay. In terms of Roche software, there is an observation slot. Okay. You can suggest in such a way like that, suggest of quadruple marker plus anomalies can as pre beta CG MOM is greater than 1.8 or 2.5. Okay. And Papa MOM is less than the 0.65 or 0.44, something like that, we can tell. So always suggest, if there is an option, okay, if there is a way, always use your observation pattern and suggest the channelizing test with reason, always with reason. Okay, so remember, people used to think like that the Papa risk start by the MOM of 0. Less than 0.44. No, actually the aneuploidy risk can start even from 0.65 MOM. That's a fact. Okay, and people used to think the annual risk of T21 for free beta CG starts at the 3. No, actually it starts for advanced maternal age, it starts for 1.8, and for non-advanced maternal age, it starts from 2.09. Okay, so these things are already there. So special MOM cutoffs, that is always useful to um, to maintain our goodwill as well as the goodwill of the referring physician. So always when it comes to double marker, we used to present as a PACA report. That means a perfect pre-analytical error assessment, an analytical interference study, a comparison study, as well as we use an additional communication notes in observation. As we know, lab clinician communication is a key in the world of laboratory medicine. Okay, so again, I will tell you, trust the one who has already proven their metal with true documented quality, highly motivated experienced team, powered with the knowledge, commitment, and superior technologies. So this is the thing we always used to tell our supporters. I mean, if you support us, then we will never let you down and we will work for your glory, because we are one good team with a good leadership. So this is a form. On the left side of your screen, you can see the prenatal screening form. Okay, and the first half of the prenatal screening form is you are used with the first half of the screening form. And if you see the second half of the screening form, apart from the smoking, NTD risk, history of T21, T13, T18, bleeding, and everything, I have added a few more things in the screening form. History of allergic rhinitis or asthma, current history of fever or acute illness, history of anti-epileptic drug use, history of preeclampsia, history of hypothyroidism, and the diabetes mellitus. I just want to know whether she is having diabetes mellitus or not, and if she is in insulin use or not. That's the main thing which I need to know. Okay, and the right side of the screen, you can see the pre-analytical error assessment form. It is divided into 4 sections. Okay, first section to be filled by the sample collection staff. Okay, and in the sample collection staff, she has to tell whether it is a serum, whether she suspect anticoagulant contamination. Okay, if she tick it as yes, then we will take the step. Okay, and she has to write the NT value, but we won't take that ND value into consideration while assessing the thing. We just put the ND value option over there to make sure the collection staff is attaching the correct scan report with the other reports just to make sure. So if we put ND value over there, they will look at the scan report now, make that, and the time and date of the sample collected, because we have to make sure we are analyzing this sample within 72 hours of collection. Okay, and the second part to be filled by the courier staff, the time at which the courier staff collects it, and he should mention it whether the sample was stored in fridge or room with AC or without AC, because we know the Papa and free beta SEG, they are not reliable or not at all stable above 25 degrees Celsius. Okay, that's a fact. And we have informed our supporters like that. Once they have collected the sample for a double marker, they should separate it in 1 hour and they should keep it in fridge. Okay, and the last part is filled by, second last part is filled by the laboratory analyzing unit laboratory staff. They will note down the time, they will note down the date, they will note down the temperature of the sample, the bulk of the sample which is received. They will check the label, they will make sure the extract is there, they will check for the leakage, they will check for the hemolysis. The point to be noted, a protein called Schwarzenegger protein is there, which looks like Papa. Okay, and that protein might lysis Schwarzenegger protein which looks like Papa, that can falsely increase Papa level. Okay. Then they will check whether scan report is available, screening form is available. Okay. And whether the screen form is perfectly filled and everything. Then they will proceed it to me or the respective doctors, and they will just take whether it is eligible or not. Then they will proceed it to double marker analysis. So this is a pre-analytical error assessment form. So I hope, as the time is up with you, I know I went a bit quick. Okay, so that's it from my part. Dr. Hari Shankar, SRL Diagnostics. Thank you.
Thank you. Thank you, Dr. Hari Shankar. That was excellent. You had a spellbound audience, starting from your definition of trust to how you unfolded your story. So as lab workers, we all are faced with the questions of who, when, why, where, how. But you have highlighted how, and you have analyzed it in a very logical manner to a conclusion. So we will take any questions that have come on the chat. Yeah, the first question is from Dr. Rahul, who says, conversely, did you get any cases where parameters were falsely elevated for one or more?
Shall I, ma'am?
Please.
Okay. Yes, sir. I have got cases because these things has been formulated on my experience of nearly 4.5 years experience on this double marker. So the first case which I got experience is this allergic rhinitis. Thing is, a patient came. It is from I remember that patient was from Government Hospital Chinnakada, Kollam. That patient, in scan report of that patient, the NT was 4.2 or something like that, and the free beta CG and Papa levels were pakka normal, and the Papa was high. So the MOI was naturally the MOI will get high. Okay, so naturally the gynecologist and the radiologist was Isolatul madam. She is very supportive. Okay, so she asked me like that, Hari, I have heard in such a like that in these kind of cases, Papa can get very low. Why the Papa is very much high in this thing? Is our things everything okay like that? At that point of time only I started studying that, and I've got few articles regarding that. I have taken the history, and the patient was having allergic rhinitis, and she was in training for allergic rhinitis. And after that, I included just allergic rhinitis and asthma in our screening form. And I started getting people with asthma and allergic rhinitis. And out of 100 patients, nearly 60 to 70 patients who are having asthma or allergic rhinitis are having Papa value on the high side. I have a few documented cases with me. Okay, so that was the first thing. And the second thing, at the time of COVID, a patient came from, I think it was from Kerala, Kollam district, Kadakal region. Okay, that a patient came from GH of Kadakal. Okay, I think the referring doctor was Dr. Asha J. Babu. Okay, from there, the patient double marker has came. Okay, and her report was the free beta CG was very much high. Free beta CG was very much high, and she was having a kind of advanced maternal age, not too much, some 36 or 37, something like that only. At that point of time, okay, she was not having any risk, but she was having, nowadays, we will tell high risk or low risk. Okay, initial time, we used to tell that there was high risk, intermediate risk, and low risk. Now people have forget about the term of intermediate risk. Okay, that intermediate risk thing is very much important for, as far as I'm concerned, for advanced maternal age. Okay, so that patient got intermediate risk in terms of that very high free beta CG level. Okay, in T21, free beta CG MOMs are very, very sensitive, very, very sensitive. Okay, so I asked the patient, and the thing is like that, she checked for COVID and she got COVID. It just confirmed. Okay, it was nearly some 12 weeks. She was nearly getting to 12 weeks only. I told to get a repeat sample after a kind of 1.5 weeks, just for a study. I hold the report. Okay, she was not too symptomatic. After some 1.5 weeks, actually at the brim of her criteria, I mean some 13 weeks fight or something like that, she got the report, and the free beta SCG level was much more better. It was not so raised. Okay, then I went digging on that. Of course, we know the relation between the COVID and IL-6. Okay. Then I went digging, and if you got articles really, a few articles had been received relating the relation of IL-6 with the free beta ICG. So then I thought like that, where all IL-6 can come. Of course, fever, any kind of acute illness, any kind of grave inflammation, these things can come. Then I also included the fever, the illness part in the screening form. So these kind of experiences take me to present this thing with a confident level with you.
Right, right. There is another question regarding vanishing twin. Is double marker risk assessment reliable in case of vanishing twin?
In case of vanishing twin, double marker, if you tell, is a point of reliability is a question. But first of all, we should look whether they have really mentioned about the fetal pole. The presence of the fetal pole is the most important thing. Okay, but as they have mentioned the word vanishing twin, in that you should consider the contribution of pre-beta and papa from that twin counterpart also. Okay, if the free beta HCG MOM, okay, in this point of times, we cannot think about T18, T13 stuff. We should focus only on T21. Okay, so in this point of time, if the free beta HCG MOM is somewhat near to 2.09, okay, getting more than that, or and the free beta HCG is somewhat near or higher than 2.09, and papa MOM is less than or equal to 0.65. Okay, just tell them like that, suggestive of second trimester follow-up study. In the bracket, you can put quadruple marker plus anomaly scan, as free beta HCG MOM is greater than 2.09 if the maternal age is greater than 35 years, and if the maternal age is less than 35 years, free beta HCG MOM greater than or equal to 2.09, and if the maternal age is greater than 35 years, free beta HCG MOM is greater than or equal to 1.8, and free beta and papa MOM is less than or equal to 0.65, and the presence of as the pregnancy is vanishing twin type. Okay, so 3 reasons: suggestive quadruple, suggestive second trimester anomaly, second trimester follow-up studies, quadruple marker plus anomaly scan. Reason number 1, free beta HCG MOM thing. Reason number 2, papa MOM thing. Reason number 3, vanishing twin thing. Okay, but if there is none of the MOMs are supporting you for another chemical study, just tell a 4D anomaly scan. Okay, that's all.
Right, right. I don't see any more questions. There are lots of comments, compliments. Very good presentation, crisp presentation. We want many more from you, Dr. Hari. And the form that you showed, documenting the pre-analytical errors, that too would be very useful in practice.
Yes, ma'am.
And you're adding whatever experience you're gaining, as you said, you're adding on to that form too. So I have taken an image, and with your permission, I'll share it on the WhatsApp group so that others can gain from it. So that others can gain from it. Just check if there are any more. That's it. That's it. No more questions. Thank you very much. And with that, we'll come to the end of today's session.
Thank you, ma'am. Thank you, Professor. Thank you. Thank you.